Hi, this is Clyde Yancey. I'm delighted to bring the American College of Cardiology show at AHA 2022 to you today for your ability to access and appreciate the incredible science that was released at the American Heart Association Scientific Sessions 2022. I want to begin correctly though. Ordinarily, you would see and hear the face and voice of Dr. Valentin Fuster. This is just temporary. Dr. Fuster will be back. This is a big space for me to try to fill. Thankfully, I've got wonderful colleagues to help us do that. But give us an opportunity to bring the cardiology show to you and know that Dr. Fuster will be back. Let me introduce my incredible colleagues. I want to start to my left with a dear friend and colleague, Dr. Bonnie Key, who's at the University of Pennsylvania. Bonnie, thanks for being here today.
Thanks so much for having me, Clyde. It's so great to be with you.
And then I'd like to introduce a new friend, colleague, Dr. Mark Rule. Mark is Canadian, but he is a cardiothoracic surgeon. Thank you so much for being here.
Thanks very much for the invitation.
And then to my right is yet another friend and colleague, Ajay Katani, who's at Columbia University and director of the Cardiac Catheterization Labs there. Ajay, thanks for being here.
Thanks for having me.
And then in the spirit of yet another new friend, Dr. Usha Tedrow from the Brigham and Women's Hospital in cardiac electrophysiology, but we're going to be a general cardiologist today. She's with us, so thank you so much. I want to also begin in a little bit of a different way. If you're looking at your feeds this morning, you're seeing late breaking news coming from the AHA 2022, announcing the results of SPORT, S-P-O-R-T, a very clever trial done by investigators at the Cleveland Clinic, comparing a small dose of rosuvastatin in persons at risk for cardiovascular disease versus all of the over-the-counter preparations that we typically see our patients indulge. Red yeast rice, cinnamon, garlic, turmeric, all of these things that cost money and that patients really swear by and would rather take those agents instead of the statin therapy. How appropriate to say, let's just test and see, compare it to a small dose of a statin. What's the outcome? The statin, 38% greater lowering in cholesterol levels, LDL. That really is the take-home message. It'll be in the news. Your patients will hear about this, but we want you to hear from us first. This really is definitive evidence that we have strategies now that will help us understand the best way to approach this lipidemia, even when we incorporate the kind of information that consumers see and read all the time. So let's enjoy the cardiologist show. We've decided to partition the new information into three big buckets. So bucket number one is heart failure. Surprise, surprise. Bucket number two is coronary disease, ischemia, et cetera. And then bucket number three is more of gamish, but predominantly prevention strategies, and especially a focus on hypertension. So let's begin. I really want to start with what I think are important heart failure trials. Let's think about TRANSFORM-HF. This was a trial intentionally pragmatic in design. And Ajay, I'll come to you in a minute to help us understand what pragmatic actually means. But it was a comparison of two loop diuretics, furosemide versus torsemide. Why? Because there's at least pharmacologic evidence that torsemide has properties akin to an aldosterone antagonist that might provide some additional benefits in the setting of heart failure, not unreasonable biology. Working through the data, randomizing patients in a large trial with very simple strategies. Once the data came forward, all comers, but hospitalized heart failure, which I think is important, no statistically important difference between the two diuretic arms. What was also very evident was that the patients, predominantly because it was from a hospitalized setting, had a very high event rate, Bonnie. I mean, it was pretty incredible, which may have made it difficult to show some differences there. We also don't have a full appreciation for the things we might have seen in a clinical trial, like biomarker profiles, which they varied, like cystatin levels, those sorts of things. But regardless, the big picture question was answered. And we need to have trials like this to help us answer these questions. Ajay, what can you tell us about these pragmatic designs? Because there were several studies that really heralded this pragmatic approach.
Yeah, I think for the audience, it's important just from a clinical trial design standpoint to understand that the idea here is that there's so many things we do in clinical practice that have not been studied. And we want to gather evidence-based medicine to sort of determine if things are better than others, because otherwise you're going by anecdote. I think this may work. This seems to have worked in my last 5 patients, but that's not the way to practice clinical medicine for the most part. And that's why we love cardiology so much. And so the idea of a trial like this is to take a simple question and to use EMR-based solutions to get a simple answer in a relatively cost-efficient way, and to be able to do it fast. Because so many trials that people don't actually know this about them take time to enroll patients because they don't meet the inclusion and exclusion criteria of the trials. So for every 10 patients you screen, you may just enroll 1. And then at the end of the day, you may get an answer, but that didn't apply to the other 9 patients who were excluded. So pragmatic trials try to overcome that by designing a simple question and answering it efficiently.
So Bonnie, Ajay gives us a lot of the benefits of a pragmatic design, but what about the downfalls of a pragmatic design? Is there enough fidelity? Do you get enough data? Is there something that we miss when we do a pragmatic design?
Yeah, that's such a great question. And I actually, as someone who does very detailed phenotyping, I do appreciate those pragmatic trials because of its ease of implementation and its feasibility and really leveraging our existing resources. But what don't we get? We don't get that detailed data, that detailed phenotypic data to really understand the why. And I think that's what's missing from these trials. But I think in terms of efficiency, it's great.
Yeah, and I do like the idea that they bring the everyman patient in. So there are almost no exclusion criteria, and the data are readily available to the extent that the EMR is available to really provide that information. So Bonnie, given the summary I just offered the audience about IRONMAN and the caveats about study design that Ajay and I were nodding our heads agreeing, there are some take-home messages. What do you think?
Yeah. So certainly there are these caveats in terms of study design. There are also many rigorous components too in terms of the blinded endpoint adjudication. I think to me, the take-home message is that we should be screening our patients for iron deficiency. And if you look at this trial in the context of the totality of evidence in heart failure, iron deficiency is a major modifiable risk factor that we should be addressing.
So, wow. Coming back to my general cardiologist, think about what you've learned already in the show. You've learned that statins prevail for prevention compared to over-the-counter agents. You've learned for the patient with heart failure, the choice of loop diuretic really is about exigencies, what's available, what's on the hospital formulary. Now we learn that, even though it seemed a little bit counterintuitive, bringing patients in for maybe monthly iron infusions that are iron deficient and have heart failure might be a benefit. And the benefit, Bonnie, was on heart outcomes.
Yes.
It wasn't just functional capacity and quality of life. I know you guys are anxious for us to get away from heart failure, but 2 more conversations about heart failure. One, Mark, I want you to talk to us about the ECMO trial and the fascinating data on CRISPR-Cas9 therapy to, and I say this carefully, cure TTR amyloid. So Mark, the ECMO data, tell us about that.
Absolutely. I think, this is really important. It's a small trial, but it's so important to finally get this type of information. As you all know, ECMO is used so widely around the world for many, many sorts of therapies. So it tells us 3 things. This was a trial of 120 patients performed in the Czech Republic. It shows us 3 things. First, when you need VA ECMO for someone in cardiogenic shock, it's about 50-50. I think you can speak with the family and tell them, look, there's about 50% chance that we're going to get your loved one out of this. And this trial really shows that the 50% kind of number comes out of almost all the patients who were treated with ECMO. Second, there's no rush to get into ECMO. And these patients were sick. More than 70% were on mechanical ventilation. They were all on vasopressors of some sort. The lactate at baseline was about 5 millimole per liter. And yet, the conservative therapy, if you will, was to wait until the lactate would rise by another 3 millimoles per liter.
While still doing other procedures.
Exactly.
Right.
And in the conservative group, it's not that they didn't get ECMO. In fact, many of those patients ended up getting ECMO at the end.
The crossover was considerable.
Right. And so overall, the trial had a lot of ECMO patients with this kind of overall mortality once you're on ECMO of about 50%. So all it tells us is that you can wait a little longer. Because ECMO, as you know, is associated with complications.
That's a great take-home message, that you can at least pause a bit and see how the patient does over those first several hours.
But the last thing I would say, Clyde,
Yeah.
is that we don't have all the data yet because these patients were older. 66 years old was the mean age. And I think that's key, right? How often do you put a 66-year-old on ECMO? This is really not your typical population. Usually you're compelled to do it in a 45-year-old or, I mean, I don't want to have age bias here, but I think, you know, the response is very different. Someone on ECMO at 66 years versus 42 years of age, it's a very different biological response. So I think we need more data.
Cardiologist then, because, I mean, this is doing a trial in shock.
Yeah.
Randomizing people to a conservative strategy. I mean, it's almost counterintuitive. What's conservative in shock care versus early VA ECMO? So as an interventionalist, what do you think about doing that kind of study, and how do you take home a message from this?
Well, first, I agree with the points Mark made. I also think that it's so critically important for us to do trials in shock, because there's a lot that we do that we think works and what hasn't necessarily been proven. The advantage of a study like this that really randomizes patients to a therapy versus no therapy, I think, is if you question whether the therapy works at all. And I don't think that's where Mark's coming from. I think there are other people out there. Then you really need to keep the crossover low. Because if you look at the Kaplan-Meier curves within this study, there's actually early separation and then they converge, which could be the folks that waited and then they started doing better once they were up titrated. So there's kind of two questions. One is, does it work or does it not work? I think many of us that do this feel that it works. So the question then becomes, when should we institute it? And that's the points that Mark's making.
Well, Mark, thanks. That's great. Bonnie, is this the dawn of a new day using CRISPR-Cas9 gene editing therapy for specific disease processes, meaning whether it's a gene target, and what happens for polygenetic diseases?
I think it is. This is a revolution in modern day medicine to see this as a reality. It's an amazing study in terms of small numbers, of course, proof of principle, 12 patients, but with TTR cardiomyopathy, which we all know is a disease that is under-recognized and carries significant morbidity and mortality. But to use this technology, CRISPR-Cas, to just completely modify the disease and to see these sustained decreases that for a long time after just one injection in TTR levels, it's amazing. And I think it opens up a whole new door for many other diseases, hypertriglyceridemia, for example, sickle cell, many others.
So what I was really struck by was as they were building a vector, it was easy to know the target because we've understood the etiology of TTR amyloid for some time. But they also took great caution to look for the one vector that had the least off-target gene editing effect. And that's the kind of care and precision we'll need to move this forward, because all it will take is one unexpected off-target consequence, and then what?
Yeah, that's a great point.
I'm seriously now considering that this is the dawn of a new day. I mean, just as a clinician scientist, and I know your profile, and I know that's an apt description of your work, how do you digest this new therapeutic strategy?
I think it's so exciting. I think it really is a dawn of a new day, as you say, because the fact that you could have this really targeted therapy that has the long duration effect that they were able to show, it's amazing. It makes you think of all the other sort of single gene abnormalities, whether it's Lamin cardiomyopathy, all the arrhythmogenic cardiomyopathies that are out there, that if we knew how to get to the patient at the right time and deliver the therapy at the right time, that you could really save some of these people in a way that we couldn't before. All these amyloid folks, we do so many things just to try to keep them moving along, and we don't really have anything that corrects the root problem. And this is really, for the first time, something like that. It's really exciting.
And think about the explosion of science in this field.
Yeah.
We've started with compounds that impact the misfolding. We've got the next wave of compounds that are silencing RNA compounds. And now we've got CRISPR-Cas9 all targeted towards amyloid. And we're learning that there's a lot TTR amyloid, wild type especially, than we thought.
Absolutely, really exciting science. That is game-changing. I think the thing that we need to do as a community, though, is make sure these are accessible to our patients in terms of cost and so forth. That's to be determined, I think.
But you know, you bring up a very interesting question, and I don't want to go too far off our targeted agenda here. But Ajay, how do you do cost effectiveness when a therapy is given just once? How do you figure that out?
It's super hard. And I think, you know, especially for something where you're fundamentally affecting the biology of the disease, it's basically, in a sense, curative. And so it just becomes hard to sort of do the standard gamble calculations or the trade-off calculations, because you're essentially eliminating something versus living with something.
I mean, Bonnie, you're exactly right. When you looked at the data, there was no area under the curve. It went to zero. That was pretty remarkable. Okay, let's change gears. Let's talk about ischemic heart disease. This is still one of the most important issues, not just in cardiovascular medicine, but in society. So when we think about this, we all were in the room when we heard the original results of ischemia, trying to think about a conservative strategy versus an a priori invasive strategy. And as we saw the data come forward, there was no evidence of superiority, but there was a directionality seen in the last year of the trial that seemingly was in favor of the invasive strategy for cardiovascular outcomes. And so we all had this anticipation. Can we get more data? Can we follow up and see what happened? So we saw the results of ischemia extend.
First, there's a misnomer out there that the ischemia trial is about PCI versus medical therapy or surgery versus medical therapy. It's really a cath versus no cath trial in patients that have high-risk stress tests. And just as you said, I mean, the initial trial design was to determine whether that invasive strategy could reduce cardiovascular death or MI. And because of enrollment issues, the endpoint was extended. But at 4 years, there was a reduction in cardiovascular death or MI with the invasive arm. And so we needed longer-term follow-up to see what would happen. And in this preliminary report, and this is a preliminary report of sort of extended data out to follow up a little bit longer than that, 5 years or so. In this report, we see a reduction in cardiovascular death because now double the deaths have occurred almost. And now we see this, except there's a side effect of non-cardiovascular deaths going up. So overall death, there's no difference. So what do we make of this? It becomes very, very challenging. But I think for me as a clinician, defining anatomy and looking at multi-vessel disease is, I think, an important facet of what we do. And I went into cardiology to prevent cardiovascular events. So to me, this gives me an idea of if the patient truly has multi-vessel disease, I should be speaking to someone like Mark. We should have an open and honest conversation because we know that any procedure we do subsequent to that has side effects associated with that, including non-cardiovascular events. But I think it gives clinicians more information to make those decisions.
Great summary. But now, Bonnie, I'm going to come back to you because these non-cardiovascular events, we were really handicapped by the design. Again, a pragmatic design, going back to our earlier conversation. The way they did it, and great investigators, terrific investigators, capture vital status from all of the countries that participated. One couldn't provide data. That was 22 deaths. No evidence to adjudicate the non-cardiovascular deaths. So we don't know if they were cancers. We don't know if there was some other interesting aberration that nobody expected. But we see the signal of non-cardiovascular deaths sufficient to mute the benefit on cardiovascular death. Basically prevented us from having the answer to a very important question. What are your thoughts about that?
You're absolutely right. I agree with you. We really need that granular data and we need to understand this better. I'm actually really worried that these are cancer deaths. We know about that intersection between cancer and cardiovascular disease, and they're competing risks for each other in terms of cause of death. I really think we need that data, and if there's any possible way to get it, at least in a subset, maybe in the US, through queries of Social Security and Death Index.
Yeah,
perhaps.
And there was even one mention in the original report about radiation. So to be determined as we go forward. Mark.
If I may, I cannot hear about ischemia extent without interjecting, so my apologies for that. But I think the points that you made are so well taken. And first, it's really important to emphasize AJ's point. It's not even invasive versus conservative. It's initially invasive versus initially conservative. And let's remember, in ischemia, revascularization was allocated based on the angiogram, not based on the CT scan. So to have the interpretation that, AJ brings me an angiogram, this patient has 3-vessel disease, maybe due to ischemia, perhaps we should not revascularize. This is not at all what ischemia showed. So I think it's very important to know that. Revascularization was essentially an observational study allocated with confounding medication and residual confounding and all these things. So anything that looks at revasc versus medical therapy in ischemia is an observational comparative effectiveness type of study, right?
So what a great segue to RAPCO. I mean, this is such an important study. In this country, we still do a lot of coronary bypass grafting. Infrequently, maybe rarely, do we use the radial conduit for bypass purposes. We use saphenous veins. Sometimes we do either a connected mammary or a free mammary artery. So RAPCO gave us some very important information, Mark.
Absolutely. RAPCO is the first trial to individually show an advantage for any form of arterial graft, essentially. Even the mammary to be LED, this was mostly derived from observational studies. There was a small stand-in-Y study that was also positive, but really RAPCO is unique in that way. That being said, the trial was not designed to look at major adverse cardiac events. It was a patency trial. It's an old trial from Australia, started in the 1990s. And essentially now we have 15 years follow-up. There were two arms to it. There was an arm that compared the radial artery to the right internal thoracic artery, but as you said, performed in an aortocoronary fashion, so anastomose onto the ascending aorta, which is probably not the most powerful way to use the right internal thoracic arteries because there are additional technical caveats to using it. And the second arm, about 225 patients, first arm was just shy of 400 patients. Second arm was the radial versus the saphenous vein. And these were older patients by about a decade. And basically what came out is that with regards to major adverse events, which non-traditionally included all-cause mortality in the trial, the radial artery was superior in both arms, actually, or either arm, I should say.
So we're going to get a little quick catch-up for the general cardiologist. So Usha, let's have a conversation. So if we're thinking about prevention right now, statins still prevail. If we're thinking about heart failure, the choice of the loop diuretics is whatever is available. If we're thinking about iron deficiency, we kind of have to give it some consideration and do the screening. If we think about this exciting new information, maybe this is the dawn of a new day and we can use genes to help us. And people like me and Ajay who take care of really severely ill patients just saying, okay, we can do randomized trials in people that are desperately ill and we can inform choices about something as invasive and expensive is VA ECMO. And now we think about coronary disease, and for that general cardiologist, we can say, and I think this is the right thing to say, use your clinical judgment. So if your judgment says you need to know, then it's appropriate to take an invasive strategy a priori and treat accordingly. If your clinical judgment, perhaps based on a screening examination of intermediate risk or low risk coronary CT or stress test, perhaps you do want to modify risk factors and use GDMT. So, Usha, as a general cardiologist, you're getting great information today. Any other things you've gleaned so far?
I think that there's so many things we've talked about already. I think a lot of them get back to talking with the patient and making sure that you have some kind of shared decision making, even picking a statin for a patient who would rather be taking their red yeast rice than taking a statin involves talking with the patient. A patient that may have competing risks when you do their coronary angiogram, deciding whether to do revascularization. That's all about both the two of you speaking with one another, but also the clinician speaking with the patient and making the right determination there. And I think that that's really what's emphasized. I think it's so incredible, the ECMO trial, that you can do such trials on such sick patients and get the important information. I don't know how much that informs the general cardiologist there, but we leave that to the specialists to decide.
What do you think about our conversations about clinical trial design? Because it really does influence not only what data we can receive, but the quality of the data. What are your thoughts about the clinical trial design?
Yeah, I think the pragmatic design, like we talked about, it's financially feasible. It's a way to answer some of these questions that I think ordinarily we wouldn't even be able to answer. But I think that the problem with those types of data sets is that there's so much uncontrolled data. You don't know what judgment the clinicians were making about their patients when they chose a certain treatment strategy. And so it's really tough. You need both the randomized data and sort of the pragmatic trial design, I think, for both. And we just have to know when we're, as the clinician, interpreting the results of those trials, to take that pragmatic design with a little bit more of a grain of salt and understand that those are people making their own decisions based on what they know at the time.
So Usha, that's a great segue to the last part of our conversation, because now we're going to talk about a classic randomized controlled trial, the prominent study, and yet another pragmatic design, the DCP study. And that will let us segue into what's latest and newest about hypertension therapy, including device intervention. So Bonnie, let's talk about Prominent. We have had this conversation on the table for so long. What do you do about high triglycerides?
I know.
Catch your breath.
It's
Catch
I
your
know,
breath.
so difficult to manage and decrease. So many patients have high triglycerides level, and we're not talking pancreatitis level.
Yeah.
We're talking elevated, that we know is associated with elevated cardiovascular risk, right?
Strongly associated.
Yeah.
But the question becomes, is it modifiable? And if you modify it, does it make a difference?
If you modifiable, does it make a difference? I think that's the question, right? In
And
terms
so
of
what
the
did
outcomes.
Prominent tell us?
So I think with Prominent, what we learned is you can decrease the triglyceride levels, but it doesn't make a difference in terms of outcomes. But this was a population on a background of statin therapy, many of them high-dose statin therapy. So I think when you're competing against that, such effective therapy, statins, so good in terms of decreasing morbidity and mortality, it's hard to overcome that. I think the other thing that we saw in Prominent is we saw an increase in the ApoB levels.
Correct.
So I think mechanistically there, that may be the issue, and that may be what we need to address as a field in terms of triglyceride lowering. We need to also decrease ApoB levels.
And we also saw a change in renal function, and we
Yep.
saw an increase in thrombotic events.
Worrisome, yes.
So I think it was presented correctly, especially with the directionality of the ApoC3. The VLDL went down, and of course the triglycerides went down. There are uncovered risk burdens for ischemic heart disease that are not fully addressed with statin therapy. We know that. Whether those burdens are pro-inflammatory or fall into the entire space of not just LDL lowering, but ApoB or non-HDL lowering. And we can't get fully there with statin therapy. Is the fibric acid derivative the way we get there? That's the question.
Yeah,
Yeah.
I think not right yet.
Well, let's switch to DCP. This was a pragmatic trial done in a VA population, so predominantly men, with hypertension. And boy, was this not the question of the day. Anyone who treats hypertension has struggled with this. All of our disease-modifying therapies in the setting of hypertension were at the benefit of exposure to chlorothalidone. That was brilliantly summarized when the trials were presented. Reduction in heart failure, reduction in stroke, improved morbidity, mortality, even overall mortality, which is a hard target to reach with chlorothalidone. So many purists would say chlorothalidone should be your de facto thiazide diuretic. But HCTZ is so ubiquitously available, so inexpensive, and it works to lower blood pressure. So this needed to be done to see if the chlorothalidone was really superior. Had I put my nickel down on the outcome, I would have voted on chlorothalidone. That reflects my clinical practice. But what we saw instead was a pragmatic design. I thought a really brilliant execution of a pragmatic design, by the way, that demonstrated absolutely similar outcomes, regardless of which thiazide diuretic was used. And so one has to feel as if treat according to what's available, to what's affordable, to which patients can tolerate. But once again, we saw that both regimens lowered blood pressure and both regimens lowered events. And so not just the general cardiologist this time, you're off the hook, but the everyday practicing physician, family practice, internal medicine, the advanced practice providers, if you're treating someone with high blood pressure, man, I gotta say this, the numbers really do matter. And we have to lower the blood pressure to lower the event burden. But maybe there's a way to lower the blood pressure that is either in addition to or instead of drug therapy. And you spent a lot of time in this RDN space, and we saw not only new data, but a new meta-analysis that you yourself brought forward. So really help us with that.
Yeah, I think two aspects. I think to echo your points, medications work to lower blood pressure. There's no question about it. One of the critiques, by the way, that I'd seen about the trial you mentioned was that it was 97% men. It's a VA-based study, so that's where that was no fault of the investigators. Of course, we need to broaden the patient population of these studies to include more women and the like. But in this case, it was because it was in the VA. From the standpoint of device-based therapies, the idea here is that medications work, but yet hypertension remains such a big public health problem because meds are not taken by our patients as frequently. We have to emphasize that more aggressively. Lifestyle modification, the same thing. But there are devices out there that could potentially lower blood pressure, and renal denervation has received a fair amount of interest. Here at this meeting, there's 2 trials. The first was SPYRAL on med, and that data is sort of the on medication trial data of the Medtronic device. The idea here is to compare renal denervation plus medications in the background to a sham control. And the trial actually missed its primary endpoint in comparing those 2 together, although office blood pressure was lowered with the device. One of the interesting facets of the trial, though, is over the follow-up period, and a lot of this was done during COVID, in the sham arm, medication burden went up. So in a sense, the device is competing against an increasing medication burden in the other arm, which is why there should be no difference typically between the primary endpoint. The data I presented was with a different device, and we were able to stabilize medications at baseline. So the medications didn't vary in the 2 arms. And what we showed at 2 months is across populations enrolled, blood pressure was reduced with the device compared to a sham control. So I think the message here is that this is potentially an adjunct to medications. We have to do everything we can to diagnose secondary hypertension, to emphasize lifestyle modification and medication adherence. But for folks that still have elevated blood pressures, as you said before, we got to get the blood pressure down, and this may offer an opportunity.
So how close are we to getting approval for a device? I know that we've gone from the first version of the devices, the 1.0 versions, if you will, to devices that are more sophisticated now and seem to have potentially more durability. How close are we to bringing this into clinical practice?
My sense is that this will be reviewed by the FDA, and we'll be hearing more about this in the upcoming year. The approvals could happen as soon as later this year, maybe next year. And then it's on us as clinicians, because this is not something where we just want to start denervating patients. We have to come up with an adequate treatment pathway that emphasizes going out to patients in their community, emphasizing lifestyle modification and meds, and then in the appropriately selected patients, renal denervation. We also have to be circumspect about the drops in blood pressure to expect. This is not going to be 20 millimeters of mercury or more. These are going to be, more modest drops, but yet nonetheless effective.
But at a population health level, it may be sufficient. We've had a great discussion, and I really appreciate your support, because it's a hard seat to have, one that was held by Val Fuster before, but you have been wonderful colleagues. I really want to send some take-home messages to the audience. So I want you to kind of formulate your thoughts for just another minute. First, I want to remind everyone once again that this program only exists because of the sponsorship of the American College of Cardiology, because of the leadership of Val Fuster. And so we're indebted to his vision and to the college for allowing us to take the time to come together and bring you this information in a crisp, hopefully palpable and meaningful way. So thank you for your attention, and thanks to the college, and special thanks from all of us to Dr. Fuster. So Mark, I want you to begin.
Thanks, Clyde, and I'm really honored that you're starting with me. Maybe I'll just coin in something I tell my trainees, and it does relate to ECMO-CS and to ischemia in some way. And it relates to, especially us surgeons, we may have a tendency to jump the gun, apologies for the expression, but to intervene very quickly on things. When you really have a choice and a dilemma between a conservative approach and an invasive one, if you don't have data to support the invasive one, just hold back a little bit and stay with the conservative approach. Because if you start, for us surgeons, if you start by operating, well, then you can no longer be conservative afterwards. But if you start by being conservative, you can always intervene later, right? And I think ischemia, it's pre-angiogram, again, I do want to emphasize, but ischemia tells us that. You don't need the angiogram for this patient who came in with maybe semi-ACS or so. You don't need to proceed right away with it. Once you have it, obviously the data is not what ischemia tells us about. But you can hold off. Same thing with ECMO, right? These patients at 5 millimoles per liter of lactate, and you could wait until it continues to increase, see where it goes. So I think that's an important take-home message.
I really like that idea that you don't have to rush. You can start conservative, then escalate as necessary. And I think that applies across the board for a lot of the things we do in medicine, particularly things that start with lifestyle change. So thanks very much, and thanks for being here. And coming here from Canada, too. Appreciate that.
My pleasure.
Lucia, you're next.
Yeah, I guess I'd like to say something about negative clinical trials, because we talked about a lot of negative clinical trials today, and sometimes people have a tendency to maybe say they don't have the punch or the excitement that's associated with some of the very, very positive trials that we talk about. But I think some of the trials we talked about today really help us in terms of how we care for our patients, whether we need to have them on a medication to reduce their triglycerides at this moment in time, whether we need to pick a different type of diuretic for our patients. I think that it's actually so important that we show the negative trial results so that we can all make informed decisions for our patients.
Terrific, terrific. I think you're right. And Ajay, we'll let you go next.
Well, I'd like to pick up on something that Usha mentioned earlier, and also to Mark's point, and particularly when we're rushed, we feel so almost paternalistic to patients and say, you need this. This is what you need, because this is what I think you need. That's the corollary and the byline. And all of these trials emphasize the point that these are decisions we make together with patients. And so it's not that they need this, it's I think this might be better. We might recognize that trial data may come along actually refuting that. And let's talk about what works for you to achieve the best outcome. And that, I think, summarizes a lot of the conversation that we've been having.
Bonnie, we have collaborated over the years and talked about so many topics, and this was a great conversation this morning. What's your takeaway for the audience?
Yeah, well, thank you, Clyde. It's been so great to be sitting next to you here, and we all send our best wishes to Dr. Fuster. I think my take-home messages are in line with the rest of this great group. I think our responsibility as physicians is to take the available evidence and present it to our patients in a digestible format, and present to them the pros and cons, and together make a shared decision. And I just think also our responsibility as physicians is to make sure that these therapies are accessible to our patients and to the diverse community.
That's great. This really has been a great conversation. I think my takeaway is this, though. After 2 very difficult years, we've discovered that discovery science is alive and well. And it's been discovery science that's really changed society. It's allowed us to reduce the burden of chronic diseases, treat infectious diseases. Quite frankly, it allowed us to take care of COVID-19. We have to keep this undeniable, infatigable commitment to discovery science, because we need to answer questions. We need to help our patients. We need to know, does this work, in whom, and what can we expect, and what are the risks, what are the harms? The other thing that was prominently mentioned at AHA 22, and I'm the right person to articulate this, was the importance of incorporating health equity in everything we do, whether it's the referral for RDN, whether it's today's messages about the upcoming atrial fibrillation trials, who are we studying, whether it's CRISPR-Cas9. If this is the dawn of a new day, let's let everybody experience that dawn. And certainly in the operating room, I mean, let's make certain that if it's bypass surgery, if it's ECMO, if it's transplant, that we're incorporating health equity at the beginning. This has been a fabulous conversation. I think we've helped the audience understand what was new, what was important, what potentially changes the way we think and the way we practice going forward. Delighted to have an opportunity to visit with you, Mark, Bonnie, always, Ajay, always, Usha, my new best friend. So great. You're a general cardiologist and I didn't know it. This is Clyde Yancey with the American College of Cardiology, the Cardiology Show at AHA 2022 in my hometown of Chicago. Thank you for tuning in. I hope that we've given you some good information. Have a wonderful day.